Ladies and gentlemen, the first session of the medical update is the Clinico-Pathological Conference. This conference will provide a platform for meaningful exchange and collaboration and inspire us to work towards improving patient outcome and healthcare delivery. Soft copy of the clinical protocol has been shared in the various groups, and the hard copy has been distributed amongst the audience. Chairperson for this session is Lieutenant General S.C. Dash, Yudh Seva Medal, Vishisht Seva Medal and Bar, Deputy Chief of Integrated Defense Staff, Medical. May I request, sir, to kindly take his place on stage. Lieutenant General S.C. Dash is an accomplished urologist with an illustrious military career which has spanned over 3 decades. The General Officer, for his dedicated service to the armed forces, has been conferred with the Yudh Seva Medal, Vishisht Seva Medal and Bar, in addition to the Chief of Army Staff Commendation and GOC&C Commendation. General Das has an exceptional academic track record as well, being a recognized postgraduate teacher and an examiner for the National Board of Examinations.
Co-chairperson for this session is Lieutenant General Narendra Kotwal, Sena Medal, Vishisht Seva Medal, Director and Commandant, Armed Forces Medical College. May I request, sir, to kindly take his place on the stage? Lieutenant General Narendra Kotwal is a professional par excellence. Having specialized in endocrinology, his academic achievements are second to none, with multiple national and international publications. The General Officer's military career has been equally illustrious, and he has been conferred with the Vishisht Seva Medal, Sena Medal, amongst many other military decorations. May I now request the chairpersons to kindly take over the proceedings.
Good morning, General Daljit Singh sir, DGFMS, alumni of FMC, delegates, senior officers, ladies and gentlemen. We are really feeling very honored and proud to be associated with this Platinum Jubilee celebrations. And personally, I am grateful to the director and the organization committee to have given me this opportunity to be here this morning. Now, to take this CPC forward, I'll request Brigadier Pankaj Puri, the Director Gastroenterology and Hepatology, Fortis Escorts, New Delhi, to kindly come to the stage. Brigadier Puri, he has done his MBBS in 1985, and he has done his MD General Medicine and DNB General Medicine in 92 and 93, and DM Gastroenterology in 99, and he is a fellow in the liver transplant from King's George College in 2006. He has several military and civil awards. To enumerate few, he has got the Lieutenant General Inder Singh Gold Medal in 1992 and Mrs. Ranjana B's Memorial Silver Medal in Advanced Course in Medicine in 89-91. Academic achievements he has, and for his expertise also, he is associated with starting the liver transplant program in AHRR, New Delhi. He is the lead investigation in development of national hepatitis C and guidelines in India, and is the fellow of Royal College of Physicians, Edinburgh and London. He was the HOD medicine in FMC in this very institute. He was the head of the gastroenterology department in AHRR, and he was the treasurer in Indian Association for the Study of Liver.
I have now request surgical discussant, Dr. Uma Nahar Sekia. Dr. Uma Nahar Sekia, as she has done her MBBS in 87 and MD from PGI Chandigarh 1994. And she has numerous awards and publication, and her CV is very long. I'm going to it very short. She has 310 publications in international journals and less publication around 88 journals in national journals. That shows her expertise in pathology. Over to Brigadier Puri for clinical discussion.
Thank you, Chairman, sir, for your kind words. And morning, ladies and gentlemen, general officers, all senior officers. It's always a pleasure to come to this hall. This hall always has a special meaning for me, and it'll be a pleasure to be here again. So the case is from PGI, and I will try and make the best of it. You all have the protocol, and the protocol is extremely long, so I will zip through most of the things. This patient was a 46-year-old male who came to us, who presented with high-grade fever and bleeding per rectum, and he was on oral anticoagulation. The story started in 2016 when he had abdominal pain, fever, evening rise, which was evening rise and diarrhea. His barium meal follow-through, which we don't have, showed jejunal diverticuli and ileitis. FNAC from lymph nodes was reactive. IgM serology, I don't know what that was, from where, and was positive, and he was given empirical ATT with some partial response. In 2019, he was admitted in PGI for swelling left upper limb, and he was found to have left internal jugular and axillary vein thrombosis. Colonoscopy showed deformed cecum with ulcers, and there was also a thrombus in the tributary of the superior mesenteric vein. There were short strictures in the ileum. There was no evidence of AFB in the cecal biopsy. He was given steroids with a working diagnosis of Crohn's disease. In March 2019, there was some proximal muscle weakness. The steroids were planned to be tapered. In 2019, he came again in June with shortness of breath and bleeding. Clinically, there was pallor, edema, and koilonychia. There were altered bloods in the per-rectal examination, and there was some proximal muscle weakness with normal reflexes. Investigations show the hemoglobin of 5.7. I don't know if this works. The hemoglobin of about 5.7, and in the terminal events, he had leukocytosis. He had fall in his platelets. The peripheral smear was microcytic hypochromic. His INR, he was on anticoagulation, was deranged, and pre-terminally he had features of TIC. He had respiratory and metabolic acidosis. His renal functions in the end were higher. The AST was slightly higher than ALT. Bilirubin pre-terminally became high. The albumin levels were always low. If you see the calcium, the corrected calcium was always on the higher side. If you look at the calcium and corrected for the albumin, it was always on the higher side. The cholesterol and the LDL were low. Salient investigations, the first investigation showed, at first admission showed thrombosis of the left axillary internal veins. He had high SAG ascites. Now, this is nothing related to any of his symptoms. You see, the fluid had high SAG. His ADA was normal. The colonoscopy showed cecal distorted with ulcers and mucosal nodularity. And all other investigations really didn't show anything much in any of the investigations. You have the protocol, you can flip through them. Hemolytic workup was negative. The other thing which was again showing us was that the portal vein was dilated and he had ascites. On ultrasound, there was some pleural effusion and collapse of the underlying lung. Cultures were positive, and imaging we will discuss later. There was a lot of images, and in fact, a huge pile of images with CT abdomen, chest, neck, CT angiography, HRCT, and X-rays. This was the initial CT which was done, and if you can see, there was one large diverticulum here. You can see this. Let me go back. So we see a large diverticulum here, and we'll refer to it again. Most of the CT seem to be hiding more than it's showing us because we don't have a lot of the arterial phase images. You see here we have only the blood going into the renal vessels, and most of the arterial phase images are not shown, in the lack of which mucosal hypervascularity is difficult to assess. You see a lot of mucosa, a lot of mesenteric inflammation, some dilated loops. See one thickened loop here, and this is the IC wall, which is slightly thick, maybe normal, difficult to talk on just a single image. There was a thrombosis here. Similarly, we see a continuing thrombus there. The initial X-ray chest didn't show us much. And if you look at this, there's ascites. The hepatic veins look good. Overall, the liver morphology does not look cirrhotic. It looks all right. You see that the portal vein is patent. The IVC looks patent. So these, other than fluid, the liver does not look grossly cirrhotic in any way. Again, we see that large diverticulum which is there again, and we see a lot of mesenteric hypervascularity, and you can see a proper comb sign here. If you look at this leash of vessels which is here, this is a proper comb sign. And again, we see some dilated loops on that side. See a thickened loop here, again, fluid. This is subsequent CT of 2019. And if you look at this, you see a thrombus here, and again a thickened, slightly eccentrically thickened bowel loop here. This is the thrombus in the SMV. Prominent loop again, which is striking us. One leash of blood vessels, which we see out here. So there are a lot of collaterals in that area. There's a stricture here, which is definite. So the initial beta follows through had shown multiple strictures. This is one definite stricture which we are saying. So this is the initial CT report which is given was Crohn's disease and probably tuberculosis, and some abnormal vascular channels in relation to cecum and ascending colon, and multiple small bowel strictures and diverticuli with a thrombus. This is 2009, probably it's wrong, must be 19. The CT chest showed extensive opacities which were bilateral and perihilar. No significant fluid in the pericardium. X-ray chest showing ground glass appearance. And again, the working diagnosis was query Crohn's TB and opportunistic infection of ARDS on pre-dermal X-rays. He had course of management. He had chronic diarrhea and multiple venous thrombosis. He had cecal ulcers and multiple strictures and diverticuli. He was given steroids and he had proximal myopathy. And the present conviction, he had chest infiltrates, given IV antibiotics, steroids, antifungal, ATT, mechanical ventilation, and everything, and he continued to deteriorate and died. Unit's diagnosis was chronic diarrhea, which was multifactorial, probably Crohn's disease, query vasculitis, query ischemic, underlying hypercoagulable state, GI bleed with severe sepsis, ARDS, and digital gangrene, probably vasopressor related. So after the long protocol, at my assessment would be this patient at first glance had pain abdomen, diarrhea, ileal strictures, cecal ulcers. He was treated with steroids, anticoagulation, developed some proximal myopathy, bleed, pulmonary infection, sepsis. Looks like TB versus Crohn's. But everything doesn't look so simple in the end, and there are many other issues. He had thrombosis, he had proximal myopathy, he had a high SAG ascites with a dilated portal vein. There were some other things which are odd. Their AST was higher, his albumin was low, his cholesterol was low, his calcium levels were high, and his pre-terminally he had obviously sepsis and pulmonary infection. So if you look at the characteristics of the small bowel strictures in our patient, one, there were multiple strictures. Second, there was presence of mesenteric inflammation. And the third was there was associated large bowel involvement. These were three things which were striking us. If you look at the causes of small bowel strictures, there can be Crohn's, TB are the usual suspects. There are other causes like eosinophilic gastroenteritis, vasculitis, lymphoma, and a cryptogenic mucosal disease, which is called CMUs, which is associated with diaphragm-like strictures. If you look both small and large bowels, it would be inflammatory bowel disease. Infections primarily would be tuberculosis, and the rest, many of them would be secondary. Vasculitis, some of them would be PANS and BASITs, and some miscellaneous causes like NSAID-induced strictures and amyloid. The two initial differential diagnoses of TB and Crohn's, if you try and compare the two, perianal lesions would be more common in Crohn's, extraintestinal manifestations would be more common, and there would be some possible association of pulmonary tuberculosis and tuberculosis. The tuberculosis would have less commonly rare skip lesions, and mesenteric vascularity would be less common. These are two things which strike us and put in favor of Crohn's disease. Can it be TB at all? Well, this is one recently published image in gastroenterology, which is of a 43-year-old patient very close to us, which had circumferential thickening and enhancement of multiple segments of small bowels. And the laparotomy showed miliary tuberculosis. And if you look at our images, they seem to be very similar. If you look at the stricture here and you look at the stricture here, they look very similar. But there are a few things which would be odd. There's a lot of mesenteric inflammation, and there was actually a Coombs sign in our patient, and a patient had already received tuberculosis, ATT, already received treatment for tuberculosis. So our patient didn't respond, or he relapsed after the steroid. So how could it be? Was the stricture already too advanced? Was there a secondary malignancy which developed? Did he have any steroid-related infections? Or could the disease be totally unrelated to Crohn's, and is it something else? Look at malignancies. There is an increased risk of adenocarcinoma, lymphoma, and neuroendocrine tumors, which is reported. It's a slightly higher, 2 to 3-fold higher risk. The imaging is difficult to suspect preoperatively, but there can be time when you can have multiple strictures which can mimic Crohn's disease in primary adenocarcinoma as well. But I think overall, it would be a surprise and would not be my first differential diagnosis. Look at gut infections, Crohn's. CMV is less common in Crohn's as it would be in ulcerative colitis, but it is documented. And CMV tends to be a localized disease rather than a pan-enteric disease. Mycobacterium avium intercellulare, again, proximal bowel is more common, but entire small bowel has known to be reported. Histoplasmosis is the third illness, and the distal ileum is often more commonly involved. Can it be something other than Crohn's disease? When you hear hoofbeats, it's a common saying that you think of horses, not zebras, but sometimes you may see a zebra. And the problem often lies is choosing the zebra from the herd and which one to choose. GI lymphomas is a common site of extranodal, GI tract is a common site of extranodal NHL. The commonly presenting with diarrhea is immunoproliferative small intestinal disease. And the other small bowel involvement can happen as a part of enteropathy-associated T-cell lymphoma or monomorphic epithelioid intestinal T-cell lymphoma. These can affect the small bowel. And one recently, some later described entity has been indolent lymphoproliferative disorder. IPSID presents with malabsorption and may proceed to overt lymphoma as well. And they commonly present with diarrhea, malabsorption. There's dilatation of bowel loops and thickened folds, which can happen. Enteropathy-associated T-cell lymphoma usually occurs in the background of celiac disease. Our celiac serology was negative, but there can be a group which is earlier called type 2 EATL, which would happen in the absence of celiac as well. Indolent T-cell lymphoproliferative disorder can present with diarrhea, features of subacute intestinal obstruction, and can mimic inflammatory bowel disease. You will have dilatation of intestinal loops, thickened of intestinal folds, and there is a correlation between Crohn's and GITLPD as well, which has been reported. There's 2 out of 10 cases had previous history of Crohn's. Eosinophilic gastroenteritis can present with multiple strictures, but proximal bowel and eosinophilia are absent in our patient. You look at vasculitis and you see a whole pile of vasculitis from large bowel to medium vessel to small bowel vasculitis. So among the vasculitis which can commonly affect the small bowel would be polyarthritis nodosa, the small vessel vasculitis, which is Churg-Strauch or Hinox-Collin, SLE-associated vasculitis, and Behçet's, which is a variable vessel vasculitis. These are vessels which present with small bowel vasculitis and strictures. So 90% of Hinox-Collin would have small bowel vasculitis, while the others would be, as I said, the common causes would be Churg-Strauch, PAN, Behçet's. All the others would be less common. So the clues of intestinal involvement in vasculitis in PAN would be hepatitis B positive, Churg-Strauch would have eosinophilia. IgA, there would be a lot of palpable purpura. All these things were absent in our patient. Behçet's would have aphthous ulcers, uveitis, genital ulcers. Look at the last 2. SLE, which is a multi-system disorder, can present with multifocal bowel wall thickening. You can have a target sign, which is diffuse circumferential wall thickening with submucosal edema. There can be ascites, and there can be a comb sign, very similar to Crohn's disease. There can be diverticuli as well. SLE is one place where you have multiple wide mouth outpouchings involving all intestinal. And there are overlaps between SLE and systemic sclerosis, which have been reported. Look at Crohn's versus vasculitis. So our first diagnosis initially was Crohn's, and I think if you look at vasculitis, in Crohn's, you would have complications of Crohn's, like perianal disease, fistula, abscesses, which were not there. There can be evidence of generalized activity elsewhere, which would point towards these things. Predominant involvement of mesentery is something which is commoner in Crohn's, but reported in SLE as well. Other helpful clues would be some pseudodiverticular formation and fibrofatty proliferation of mesentery. While you're trying to differentiate the 2, it is well known that both IBD can be associated with vasculitis as well. And this is a little chart which is showing us how to differentiate Crohn's versus vasculitis. And if you have disease outside, involvement of other organs, and if you have lab features of vasculitis, and then you think of, or you have things like thrombosis happening, you think in terms of vasculitis. I'm going to skip over this. So our patient had multifocal small bowel strictures. There was mesenteric inflammation and thrombosis leading to malabsorption. Thrombosis per se is not uncommon. You can have arterial thrombosis and as well as vasculitis, which happen in patients as a part of IBD as well. And the prevalence of thromboembolism is about 0.4 to 0.6% in IBD, in Crohn's and ulcerative colitis. What about the ascites and the dilated portal vein? If you have a SAG of more than 1.1, it is 97% prevalence of portal hypertension. But the problem is our patient had no radiological evidence of IVC, hepatic veins or portal vein thrombosis. The liver looks good. There's no pericardial infusion. Traditional teaching is that if a patient has ascites, probably has either Budd-Chiari or there is sinusoidal involvement in the liver itself. Transient ascites is well known in acute portal vein thrombosis. While I say that, portosinusoidal vascular disease has been documented, which sort of amalgamates these diseases where there's no frank portal vein thrombosis or a Budd-Chiari, which is possible, which is available, and it can happen as a part of many immune-related disorders, hematological disorders or prothrombotic disorders where the small vessels can be involved. And the ascites can be there in as much as 20 to 50%. And subsequently, portal vein thrombosis is known to develop in about a third. A few other missing links, since we're running short, I'll skip through quickly. There are diverticuli, which can happen in Crohn's as well as in vasculitis. There was hypercalcemia, which can be more common in lymphoma and granulomatous disease, but cannot explain it so easily with the former 2. Low cholesterol can be part of malnutrition, may be part of chronic liver disease, though overt liver disease is not available. This proximal muscle weakness, this myopathy, which could be steroid disease related, but may also be a part of connective tissue disorder, where vasculitis is a part. This pulmonary involvement, if you look at related to the intestinal disease, TB and vasculitis is there, but more likely in this patient, there is a related to immunosuppression, which is flare of TB, less likely, more likely to be opportunistic infection in our patient. So if you look at multiple small bowel strictures, mesenteric inflammation, cecal ulcers, thrombosis, ascites, and pulmonary lesions, if you look at these things, Crohn's would have more likely to have multiple strictures, as would have vasculitis. Mesenteric inflammation, more common in Crohn's, also possible in vasculitis. Cecal ulcers in almost all of them. Thrombosis would be more common in vasculitis. Ascites can happen with part of low albumin, but remember it was a high SAG ascites. May happen as a part of small vessel thrombosis as well. Pulmonary lesions in our patient, I feel, were because of secondary infection, because the previous images were normal. To summarize, ladies and gentlemen, we had a 48-year-old patient with bowel involvement and multiple thrombosis. He was treated with steroids and anticoagulation, developed proximal myopathy. He had a high SAG ascites. I'm not, as a gastroenterologist, I'm not willing to ignore it, although it's nowhere in the protocol. There was a dilated portal vein. There's sepsis, pulmonary infections, AKI, ARDS, and jaundice in the end. So as a part of the differential diagnosis, I would first put vasculitis as the first diagnosis. The overall picture is Crohn's, but doesn't explain everything. The Crohn's can be associated with vasculitis, or the development of secondary infections or lymphoma is possible. Portal hypertension is likely to be a part of portosystemic vascular disease rather than overt liver disease per se. There is no features of constrictive pericarditis or no features of outlet obstruction in our patient, though we don't have echo reports, to be fair. Pulmonary infection is more likely to be part of ARDS and opportunistic infections. I think I'm finished, and I'm going to let Dr. Umar unwrap and tell me what it comes out to be. Thank you.
Brigadier Puri has very nicely brought out the various differential diagnoses related to this case. Now this is open for the open for any discussions, any comments from the audience. Yeah. Mike.
So we've all grown up admiring you. So it's an honor to be able to offer a comment. I'm a rheumatologist. So first of all, sir, SLE vasculitis, it's a male patient. So that would go against. The C3, C4 levels were not mentioned, and the APS workup also I would have been interested in. Of course, this definitely looks like a vasculitis. It could be even a vasculitis secondary to infection like tuberculosis.
Thank you. Thank you for your kind comments. But the information, there's a lot of information which is either not done or judiciously not given to keep the interest alive.
Yes, sir, I understand.
So, AVM Shankar. Until Shankar asks question, Dr. Puri, as further to that thing, CRP mentioned is normal. So in any itis, I thought that CRP should have been positive.
CRP would be positive in everything. A patient who's got significant infection, whether he has Crohn's, whether he has tuberculosis, it should be high in everything, whether it's vasculitis. So that doesn't take us.
It's not positive here.
But it's pointing towards almost nothing.
Okay.
The illness, sir, firstly, fantastic analysis, sir. That left all of us a little bit more confused. The last 4 years, from 2016 till 19, if this vasculitis, even if it developed, it should have developed much later, because there was no mention of steroids being given for the first 3 years. And I see no vasculitis it was only ATT which was given. And most of the findings which were there were already present in some form or other for the first 3 years also. So I would, my thought process might be slightly lower down the card, sir.
I'd be happy to know what's your first.
So may I come in?
I feel that maybe I'll still stick with Crohn's, and maybe there was a complication of an added malignancy because all the thrombosis and everything which did develop, so which was, with axillary vein thrombosis and everything, so possibly as a paraneoplastic feature.
Please.
Good morning, sir. I'm Air Commodore Naresh. I'm a surgeon, oncosurgeon. I'm just wondering the last, for 4 years, 2016 to 19, with the thickened bowel segments and the strictures, there's no mention of any attempt at a biopsy or anything, either laparoscopic or image guided. We are just contemplating so many things. There were strictures, there were ulcers in the cecum.
Cecal biopsies were done which were non-contributory.
Right, sir. Thank you, sir.
Yeah, please. Brigadier Muthu.
Very professorial deliberations. I wish we would do this to every patient who is still alive also. It would lead us to some conclusion at every stage. In this case, tuberculosis versus Crohn's would be the first impression the moment you see this patient in 2016, thereafter till 2019. Development of thrombosis actually takes it away from tuberculosis, or unless there is an underlying low-grade malignancy, which was itself the reason to begin with, from and especially lymphoproliferative disorder can be the reason, which can manifest at that stage. And steroid probably not having improved things to the extent that we expected takes it away from vasculitis. I would still look at either a low-grade lymphoproliferative disorder or Crohn's complicated by malignancy leading to thrombosis later.
I agree with you. They're all up in the air. You have to choose one. Every differential diagnosis has something for it or against it. And if you choose one, you look at what will explain all the things. And that's the reason to choose one over the other.
Good morning, sir. Sir, so you very well summarized the whole gamut of presentations. Possibility of, since no biopsy could document celiac disease or Crohn's disease or a tuberculosis, my hunch would be still all this could fit in a gamut of lymphoma associated with IBD or plus minus underlying celiac disease, the enteropathy associated T cell lymphomas or the subtypes of lymphomas, which is ultimately a histopathological diagnosis. Everything could just fit in with a lymphoma because he's received steroids. So as Brigadier Muthu sir told, it's only a single agent that would have partially suppressed the disease, probably. The other chemotherapy aspect, since there was no diagnosis, has not been added on. So lymphoma would be maybe a higher on the card, since we do not have other, as yet, other diagnosis probably.
So I agree with you. The lymphoma usually will be a unifocal stricture. You can have multifocal in enteropathy associated. Our celiac serology, however, was negative.
Yes.
And the non-celiac related lymphoma is less common. And you have to choose keeping that in mind.
Yeah. So some extra intestinal manifestations of IBD as well as celiac also may be that proximal muscle weakness, maybe steroid related, maybe an extra intestinal manifestation, possibly, sir. Just my contention.
I agree. That has mentioned.
I'd like to have a little more details about the pancreas, pancreatic workup. I think not many features can be explained.
Which is normal.
Any other comments? Just to support, Brigadier Muthu and Harshit regarding lymphoma, I was just thinking calcium on higher side, hyperalbuminemia, hypercholesterolemia may support a little bit of some proliferative disorder. Yeah. That's right. So to clear the confusion, I request Dr. Uma.
If I have to choose a lymphoma, I would choose a secondary lymphoma in the background of Crohn's disease. It's a long history. If he's had lymphoma with the strictures for 4 years, despite steroids, it would be less likely. So with the background of Crohn's having multiple strictures, then to develop lymphoma, and that is there in my second differential.
And in PGI, whenever there's a CPC is done, fungal infection invariably is there. And this patient has been on steroid and we know expression also. Dr. Uma, please.
Yeah, thank you, chairpersons. I feel honored and overwhelmed to be here present and to witness this 75 years of AFMC Pune celebration. And thanks to Commandant and Director Narendra Kotwal for extending this kind invitation to me. And on this momentous occasion, I congratulate each one of you of this august gathering for this celebration and each one associated with the AFMC, and to have more such celebrations and see the centenary celebrations here together, and wish that the AFMC continues to be a beacon of hope, inspiration, and excellence for the future generations to come. Thank you so much for having me here. Now, without wasting much time, let's go to the pathology. I must congratulate Dr. Puri for the very, very lucid discussion. I had a tough time in choosing the case. When I knew that a gastroenterologist is discussing a case, I thought it would be appropriate to choose a case which is close to his specialty and not give him just a general medicine case. So someone asked if the biopsy was not done or done. It was indeed done. I'll be showing that. The first slide, please. Yeah, next. Okay, so this was the colonic biopsy, which was done prior to the demise of the patient. And as you see, the mucosa is essentially normal. There's not significant inflammation, but you have small lymphoid aggregates. But you see here is an expansion of the submucosa. A lot of fibrosis and vascular thickening is seen. So it was just reported as fibrosis in the submucosa, possibly suggestive of some ischemia. Followed by this, ileal biopsy was also done. And this is again another colonic biopsy. And again, it shows essentially normal mucosa, some lymphoid aggregates which are normal to the ileal site. And again, some mucosal fibrosis and expansion, suggesting ischemic changes. Now, we do not know what is the etiology of this ischemia. Dr. Puri very well put his bet on the vasculitis. So let's see whether this patient did suffer from vasculitis or not. But I agree that patient did not respond to the steroids, which goes against relatively for the vasculitis. And this is the ileal biopsy again. So normal in morphology. No microscopic pathology on multiple biopsies which were done. Subsequently, we lost the patient and it was a complete autopsy. Brain was also examined. There was no significant abnormality on the gross examination of the brain, and there was serous effusions both in the pleural as well as peritoneal cavity, and it yielded around hemorrhagic fluid. And you see the peritoneal cavity yielded around 6 liters of hemorrhagic fluid. And the prosector also mentioned that there was gangrene on the tips of the fingers. Now let's start from the GIT, which is the main focus of the problem. If you see, this is the serosal aspect, and this is a small intestine, and it looks very, very discolored, very blackish in discoloration. No perforation, however, could be seen in this picture. The mucosal surface again shows diffuse hemorrhagic discoloration, thinning of the mucosa focally, and focally it does show some narrowing here and there. And there were some ulcers as well. Now let's see the microscopy of this. So this is the mucosal aspect, which shows some erosions. So there is damage to the mucosal lining, which means the ischemic necrosis. And again, as similar to the biopsy, you have expansion of the submucosa. And of course, there is a thickening of the serosa. And if you see the submucosa, these vessels are, if you see on the Mason's stain, the collagen bundle which is deposited in the submucosa is stained with greenish blue in color. So that signifies that there's significant amount of fibrosis occurring in the submucosa, which is of long-standing duration. So another pictures, panel of pictures to show the mucosal erosions, some ulceration, lot of fibrosis highlighted with this bluish plain color, and most of the vessels are looking clogged. They are luminal narrowing and occlusion of the lumen. So let me focus it why the lumen was narrowed. So again, another picture to appreciate this mucosal erosions. Point to note here is there's no significant inflammation. So there's no neutrophils, no lymphoid cells within the mucosal lining. The vessels beneath shows total occlusion with the thrombus. There is no itis. That means there is no vasculitis. And again, Mason stain highlighting this multiple ectatic vessels in the submucosa occluded by this fresh fibrin thrombi. Now let's see the mesentery. Now see, this mesentery is also very much discolored. You have areas of hemorrhages and small lymph nodes were enlarged. And if you see the microscopy, you see the vasculature. So all the vessels showing almost uniform pathology. So some of them had got fibrointimal proliferation and others were having thrombus in the lumen with some narrowing of the lumen. Now, this is how we dissected the mesenteric arteries. You see here, so some of the vessels did show some narrowing, and this is the multiple serial sections taken from the level of the mesentery. The mesenteric arteries did appear to be narrowed and thickened in wall. And this is the microscopic section from one such artery, which shows luminal narrowing because of this fibrointimal proliferation and some recanalization. So suggesting that this is an organized thrombus with recanalization. And the elastic stain highlighting this reduplication of the elastic lamina. Again, you can see a recanalizing thrombus here. So definitely we are dealing with a vascular disorder here, but it is not vasculitis. So what are we seeing, looking at? Another panel of pictures to appreciate again the narrowing of lumina, but no vasculitis, intact elastic lamina. And that's what clarifies that it is not a vasculitis. And of course, there's absence of inflammation. Another vessel which is showing you complete narrowing with some small capillary channel seen within the intimal areas, suggesting recanalization of the thrombi. Mesenteric arteries, again, variable size, showing the lumen narrowing and variable degree of proliferation of the intima. Now let's see the diverticula. There are multiple diverticula present. And if you see here, this is also looking very, very discolored. This is not normal color of the intestine. And the microscopy of this diverticula also showed this kind of necrosis, and the vessels within the diverticula also showed fresh fibrin thrombus without any vasculitis. Sections from the small intestine also reveal similar features: congested ectatic vessels with multiple thrombi, a higher magnification to appreciate the fibrosis, and along with that, there's a lot of fat infiltration, which suggests that this fibrosis has been ongoing for quite some duration. And another picture to appreciate the erosions of the mucosa secondary to these vascular changes. You see the ectasia of the vessels. They're all clogged and lumen is completely blocked. The mesons highlighting these thrombi, the fibrosis and erosions in the mucosa. And of course, a higher magnification to appreciate these thrombi and fibrosis. So we are sure that we are dealing with the vascular pathology. Now, what is the pathology? Let's go to the large intestine again. Again, showing multiple erosions and strictures, and there's a probe which has been passed to one of the diverticula and the perforation. See here, this is the mucosal aspect. So diffuse hemorrhagic discoloration. Some areas were relatively spared with normal color of the mucosa. And this is another area which shows narrowing, so confirming the stricture. And then, of course, diffuse ulceration and hemorrhagic discoloration with multiple diverticula. And the sections from these diverticula also showed similar features, that is, showing you submucosal fibrosis, suggesting ischemic changes. And this is the higher magnification, showing the normal lining epithelium. No increase in intraepithelial lymphocytes, no lymphoid follicles, no evidence of any lymphomatous pathology. And this is the meson, again highlighting thickening of the submucosa, and also the serosal aspect is fibrotic, along with some fat infiltration in the submucosa, signifying it chronicity. Now let's see the appendix and the diverticula again closer to the large cut. You see again, very, very diffuse hemorrhagic discoloration and microscopy showing diffuse fat infiltration. Now this was much more chronic as compared to the small intestine because there's fat infiltration. In addition, there was presence of this neutrophilic infiltrate, suggesting that there was acute and chronic inflammation in the diverticula. This is a section from the pancreas. It did show enzymatic necrosis, but other than that, the acini and the islet cells were essentially normal. Now let's see the stomach. I am very happy that Dr. Narendra Kotwal brought out the fungal thing. So obviously, when you're presenting a CPC from PGI, likely that you should consider fungal infection. And if you see here, the esophagus is normal. However, the mucosa of the stomach is diffusely discolorated with these punched out ulcers. Now, this is not the situation which we saw in the large and small gut. What we saw here is this ulceration and there's a lot of inflammation, and this is showing you fungal thrombi, right? And if you see on a closer look, these fungal thrombi were present within the vessels and also was insinuating into the adjoining mucosal surface. And the picture to appreciate a fungal thrombi, and the fungal profiles were cylinder with acute angle branching with septation, and which was confirmed on the silver stain, that is the humerus methylamine stain. So you see the septate fungal hyphae with acute angle branching, which are highlighted by this black color in the stain. Now let's come to the other part of the intestine. So you see here, we saw the small intestine, we saw the stomach and esophagus, and let's come to the large gut, essentially the in toto. Some parts were relatively spared, however, the others were grossly, massively involved by the similar process. And microscopically, the mucosa was normal. So ruling out thereby Crohn's totally or any tuberculosis. There was no granulomas as well. But if you see, there is proliferation of these vascular channels along with submucosal fibrosis. Okay. A closer look to appreciate this collection of vessels. So again, telling us that this is a vascular pathology. Now let's see the liver. It essentially looked normal on the scans. However, it was bile stained. It was slightly overweight. No focal lesion was seen. The pancreas is essentially normal. And this is a closer look to appreciate the wrinkling of the capsule, but no focal lesion or no cirrhosis. The portal vein, of course, was dilated, but there was no presence of thrombi in the portal vein. And the spleen. Look at the splenic artery, which again shows this thrombus within the splenic artery and which was showing some wrinkling of the capsule, again suggesting that is because of the ischemia, the spleen size has got shrunken. Microscopy of the liver, which showed multifocal confluent hepatic necrosis. Only some spared hepatocytes were seen, which was present predominantly in the zone 3. A reticulin stain highlighting the preserved reticulin framework, and a high magnification to appreciate some foci of preserved hepatocytes. However, essentially it was showing multifocal hepatic necrosis. The spleen showed red pulp congestion, and even the spleen, the vessels were not spared. They were showing this kind of fibrinous deposition in the wall, but no vasculitis. And the Marsh's colored blue highlights the presence of fibrin within the splenic arterioles as well. Now let's come to the terminal event in this patient. I'll come to the summary of the case. You might be wondering, what is it then? So both the lungs were heavy. They weighed around 1100 grams against a normal of 600 to 700 grams, and they were very dusky in color. The pleura was obviously lusterless with some fine fibrin tags, and the lower lobes showed hemorrhagic consolidation. And the cut surface, appreciating this hemorrhagic consolidation in the lower lobes. A closer look to appreciate this hemorrhagic consolidation, and some of the vessels did appear to be thrombosed here. And of course, it was confirmed microscopically. So you had the veins and the arteries both showing thrombosis, and the adjoining lung parenchyma showing extensive alveolar hemorrhages. And this is the elastic von Giesen stain highlighting the intact elastic lamina, again ruling out vasculitis. A panel of pictures showing variable changes in the lung vasculature, fresh fibrin thrombus to organized thrombus to recanalization. And this is the elastic stain, again highlighting the vascular changes in the lungs. So it's a systemic process of vascular involvement, predominantly involving the GIT and the lungs. However, terminally, the patient did have evidence of bronchopneumonia, as you see here, neutrophilic infiltrate within the alveolar spaces. And of course, some areas were showing organization in the form of fibroblastic proliferation. Other areas were more hemorrhagic, accompanied with edema, seen as pale eosinophilic material. And of course, you cannot get away with ARDS when you have such kind of illness. So the patient did have presence of ARDS in the form of this pink material, which is deposited around the alveolar septae, and which is brought out very well by this PES stain, which is brightly pink in color. Let's come to the heart, which is essentially normal on gross examination. The coronaries were also examined. They were normal. However, there was a presence of intramural thrombus in the left ventricle, but the coronaries dissected in the toto did not show any thrombosis or any inflammation. Now, interesting part here was the kidneys. I was a little intrigued by the pathology in the kidneys, but yeah, if you see the kidneys, they have these multiple whitish areas of necrosis. So it's again dusky discoloration. It's not the normal contour, and they were slightly small in size. The bladder, ureter were essentially normal. And the closer look of the kidney, so multiple foci of these pale areas. So it was having acute cortical necrosis in the kidneys also. The renal arteries, however, patent. There was no evidence of thrombosis in the renal artery. The cut surface of both the kidneys, you see diffuse cortical necrosis was present with dusky discoloration. And this is the microscopy of the kidney. You see all the tubules, proximal tubules have gone ischemic necrosis. However, the vessels are showing a lot of thrombi. So it was the intralobar arcuate arteries which were showing the thrombosis and not the major renal artery. A closer look of the same to appreciate the thrombosis in the renal arteries, and a panel of picture to appreciate the left corner shows thrombus, fresh fibrin thrombus, the PA stain highlighting the thrombus, and which is staining red in color in MSB stain. The glomeruli, however, did not show any pathology. However, there were presence of fibrin thrombi in the smaller capillaries. You see here within the arterioles, suggesting evidence of DIC in the kidneys as well. Another picture to show normal glomeruli. However, the capillaries were showing thrombi, smaller capillaries, right? Okay, now coming to the bone marrow, which was essentially normal. There was no granulomata in any of the organs seen. All the hematopoietic elements were essentially normally distributed. So what are we dealing with? So we are dealing with a case who had arterial and venous thrombosis, predominantly involving the mesenteric vessels, causing acute and chronic mesenteric ischemia. And in the ileum, we had transmural hemorrhagic infarction with strictures, and in the jejunum, multiple diverticulae with diverticulitis, and so also was involving the part of large gut also. In addition, there was thrombosis of the arteries in the lungs and kidneys causing cortical necrosis. In addition to that, there was invasive aspergillosis in the stomach. There was pan-acinar confluent hepatic necrosis along with bronchopneumonia and ARDS. So what are we dealing with? So to summarize, patient has got arterial thrombosis with varying stages of organization and caliber. So that means the smaller as well as medium caliber and the large caliber vessels were involved, both arterial and venous, involving the mesentery, lungs, and the kidneys. So which suggests that the patient was having hypercoagulable state. There was arterial and venous occlusion and ectasia causing ischemic changes in the GIT and mesentery. So the possibilities which one has in mind is either we are dealing with the antiphospholipid syndrome or we are dealing with thrombophilia. However, in thrombophilia, it's predominantly venous involvement. And in APLA, we have venous as well as arterial involvement. So possibly we are dealing with a case of antiphospholipid syndrome, though we did not had antibody positive. And I think cardiolipin and anti-lipoprotein antibody was not done because it was not thought of antemortem. So this patient belongs to catastrophic AVS because it has more than 3 organs involved, and the manifestations have developed simultaneously in less than a week or month's time, along with evidence of small vessel as well as large vessel thrombosis. However, you need to have a laboratory confirmation, but if you have at least 3 criteria positive in this patient, so it belongs to category of catastrophic APL in this patient. Thank you. So this is my institute view from our balcony, and this is our director office. So we know that the danger was looming right in front of our eyes, and we knew that there is a vascular etiology. However, it was so catastrophic that, and the ferociousness of the disease was so much that it took away the patient from us. Thank you so much for your patient hearing. And I feel proud to be from PGI, but I also feel that I'm part of AMMC also, genotypically. Not phenotypically, though. Thank you so much for this
Thank you,
opportunity.
Dr. Manhar. As usual, pathologist, it was a googly. We are nowhere clinical
No,
diagnosis.
right. Vasculitis, so which is okay. But yeah, the point to be taken here is vasculitis responds very well to steroids.
Steroids, yeah.
This patient did not respond to steroids at all. But someone made a comment that if we are much more wiser during the antemortem stage, probably we might have saved this patient. Probably.
That is why CPCs are done to learn more,
exactly.
to refine our clinical skills.
So it's a learning exercise for both, for us also. It's not that only the clinicians learn from CPC. Thank you so much.
We could have done some laparoscopy and the biopsy of the intestine or the...
It was done. I showed the biopsies from the small gut as well as large gut. They were all showing just ischemic changes. Yeah. There was no specific pathology could be seen. So we could not pinpoint what could be the etiology of that ischemia because this is a small endoscopic biopsy, 2 to 3 millimeters. So you cannot really make out the etiology.
Yeah. I would like to have comments of Harshit and Uday.
Hello. Ma'am, good morning, ma'am. Thank you for the autopsy findings. I have a question in my mind that catastrophic APLA, I mean, the whole original disease lasting for 4 years does not justify the whole gamut of presentation with catastrophic APS. And in a male, catastrophic APS is the final, maybe in a month or 2 when he deteriorated at the last. Yes, the overall syndrome fits into a catastrophic APS. But what about the primary pathology of the gut, the diverticulitis, the manifestations of the disease? So we yet do not have the primary diagnosis of the histopath in the sense that it may have not been apparent. Obviously, you've shown everything. So the terminal event makes it understood to be a catastrophic APLA. But what about the primary disease, diverticulitis and everything? I am not sure.
Thank you, Dr. Harshit. Well, this patient started having symptoms 4 years back, right? He predominantly had GI involvement. At that time, it was not catastrophic. However, it was not picked up during that time. He was given steroids, he was given ATT, thinking on the lines of Crohn's versus tuberculosis because the SAG was also high, right? So that time also he had ischemic changes, which could not be picked up on the endoscopic properly. And the biopsies could not pick up the etiology because the thrombosis were not seen. So it was an ongoing process, but terminally he had catastrophic APS. Of course, if he had the antibodies tighter, it would have been much more easier to pinpoint the etiology. Involvement of venous as well as arteries of all calibers. With this degree of thrombosis, there's no other diagnosis but to offer either hemophilia or APLA. But because there's only venous involvement in thrombophilia, so we rule out that. You know more than me in that.
APLA manifestation is certainly agreed upon. The only question is, has the diverticulitis occurred because of ischemic change?
Ischemia, absolutely.
Okay.
That's secondary to the ischemia and strictures.
Primary antiphospholipid syndromes in males are unusual.
Absolutely.
So secondary, I mean, we do not, I still feel there would have been something primary. Manifesting as a secondary antiphospholipid syndrome. A primary diagnosis, since there are multiple causes of antiphospholipid syndrome.
Absolutely.
So that's my.
I totally agree with that. I also would go with the idea that it is possibly secondary. That's why I didn't label it as primary or secondary. I left it at APLA. Thank you.
Thank you so much.
Yeah, Kalan Chaudhary.
Hello, I am Gautam Chaudhary, rheumatologist at Command Hospital, Chandimandir. These patients must have had a number of CBCs. One of the indirect markers of any APLAs we have found, there is a finding of thrombocytopenias. Sometimes we pick up from that only. Whenever the patients have been referred, either a deranged PTIN or obliga thrombocytopenia. I don't think this must have been seen in this patient.
There was thrombocytopenia. There was terminally. It was
Terminally, yes. But that may have been sepsis related.
It is now contributed by DIC, APLA, everything together.
Yeah,
so
please.
terminally, it would be difficult to say.
Thank you for a wonderful presentation, ma'am. I want to know that if in the course of 4 years, did he have a screening coagulogram? If he had a deranged APTT, we could have followed that up further to see what was the cause of that. And like what Sir said, thrombocytopenia, I think would be a little, it's very rare. I mean, you can have APLA, which leads to antibodies leading to an acquired kind of a thrombocytopenia, but that would be rare. We don't see that too very often. So.
Thrombocytopenia is not so rare in APLA. That's one thing. It's seen, right? So rightly pointed out, sometimes the clinicians pick up the diagnosis with the low platelet count. Now, I do not have the detailed coagulogram at the first presentation. We do not have. So I will not be able to comment on that part. But yes, of course, in the due course of the disease, in the last 4 months before his demise, we do have readings, INR deranged, coagulogram deranged, low platelet count, so which points towards a vascular etiology. And if there is no vasculitis, you have thrombosis, systemic involvement, you would suggest a possibility of APLA.
Because ma'am, if we did have a APTT which was prolonged, we would have further
but retrospectively, I can't make that comment.
Join Kavita.
Firstly, I want to compliment both Uma and Pankaj for this wonderful presentation. And I think one of the points that pointers that is towards a chronic vascular involvement is the amount of fibrosis that she has shown in the submucosa and the thrombosis of the vessels in the submucosa, which shows that it has occurred over a period of time. So for the last 4 years, the patient has been suffering, has been having small areas of fibrosis and vascular thrombosis in the mesentery as well as the small bowel and the large bowel. That is what has led to the strictures and the diverticulosis. So there's no doubt about this point, which is very nicely brought out by all the fibrosis strains that she has shown in the gut. I was just thinking that would an iron stain also have helped? Because very often these patients who have mesenteric ischemia as well as small and large bowel ischemia of the submucosal vessels shows a large amount of iron in the submucosa. I just thought that maybe that stain would have helped also.
Usually we pick up the iron deposition on HNE itself and then we order for the special stains. So however, in this case, we could not find any hemosiderin anywhere. So we did not perform that.
I have one question, Pankaj sir. If you'd known this diagnosis earlier, what is the lesson learned? I mean, how would it change the treatment?
We have a lot of rheumatologists behind, and they are the better ones to give that answer. To the uninitiated, it is a vascular involvement. To a physician, chronic disease without any peripheral thrombotic manifestations, vasculitis will be and will always be the first clinical diagnosis. APLA, I will, if you ask me to knowing it, will I give that differential diagnosis again? Never. I will always give vascular involvement first, and among vascular involvement, vasculitis first. This patient has proximal myopathy, probably a part of a connective tissue disorder. In connective tissue disorders per se, you can have large diverticuli, which can happen. You can have thrombotic manifestations and vasculitis as a part of a connective tissue disorder. So I think overall, there's likely to be a secondary ALPLA.
Possible. I won't be, that's why I did not mention it clearly, because I do not, and males, as I said, all autoimmune disorders are less common in males.
So since we have to stick to time, so only last comment by Kanode.
Thanks a lot for the deliberation. Ma'am, thanks a lot for the deliberation. Ma'am, but even after listening to your final diagnosis, I think we might not agree with it because of two reasons as a hematologist. First of all, somebody had already started the patient anticoagulation. So people did suspect a thrombotic episodes or the thrombotic event going on in the body. A patient on anticoagulation at PJ would have undergone multiple coagulograms to monitor the patient for the adequacy or the therapeutic anticoagulation. Not having a raised APTT throughout the episode while the patient was on anticoagulation and a patient for evaluated for bleed disorders would have definitely undergone a thing. So having a normal APTT throughout, it would be very unlikely to say that the patient was having a antiphospholipid syndrome for 4 years and finally ended up with that. Yes, vascular thrombosis definitely in place, but maybe we are here looking at probably some rarer vascular disorders wherein patients having endothelial disorders, genetic disorders or vascular anomalies, different types which yet need to be worked up, but labeling the patient back as a APS through and through, I agree with Pankaj Puri sir that if this patient comes back to us, we'll never ever again suspect a APS in this case.
I totally agree with that comment. So, you know, when you are on the pathology side, you have to give a final line. So this was the best final line I could fit in. And short of genetics and mutations, I cannot pinpoint the etiology.
Yeah.
You're very rightly said, in this molecular era, we should go ahead and further do something for the patient. So maybe to help any such patient which comes to the clinic in future. Thank you.
Sir, did you finish, sir? Would you like to say?
And he said, look, spider is there for everyone to see. Helped all of us to spin a lot of yarn. But the last word always lies with pathologist. I mean, as a pediatrician, we see, Anupam was commenting, we see a lot of mothers coming with recurrent abortion, etc., etc. A chronic thing goes on. Somebody said it's a final thing is, fulminant APS, and all along could have been something. And no, the things can go on. And APS is a funny disease. The thing can, all the investigation would be normal, and things could just keep on carrying on. Could keep on carrying on till again you have a clinical manifestation happening. You have coagulogram, everything coming normal, again going on, and something like this, what has happened here, could have landed us into this thing. Thank you, madam.
So thank you very much. We had a very nice discussion on clinical discussion on the protocol, good pathological findings. I think we must give them a huge round of applause.
That was an invigorating discussion. May I now request the chairpersons to kindly present the Platinum Jubilee mementos to the speakers.
Thank you so much.
Thank you, sir. May I now request the speakers to take their seats in the audience. May I request the chairpersons to kindly be on stage for the felicitation. May I now request Lieutenant General A.K. Jindal, Ati Vishisht Seva Medal, Yudh Seva Medal, Commandant Army Hospital Research and Referral to kindly present the Platinum Jubilee mementos to the chairpersons. Thank you, sir. May I now request the dignitaries to kindly take their place in the audience.
I now request the dignitaries and delegates to proceed to the front of the main building for the group photograph, following which I request everybody to proceed to Sanjeevani Hall Bridge for high tea. We request all the dignitaries and delegates to reassemble at Bharadwaj Auditorium by 10:40 hours for the next session, which is the Platinum Jubilee Oration. Thank you.